Coming up next on Another View, it's Another View on Health with Dr. Keith Newby. Today's topic, Medicare and Medicaid. Both of these insurance programs are federally funded, but who has access and how are very different. And they both cost a lot of money. So who is responsible for lowering costs, the government or the patient? What about fraud and abuse? And what is the impact of the Affordable Care Act on both programs? I'm Barbara Ham Lee. We'll have answers to these and other questions, and we'll take your calls at 440-2665 or 1-800-940-2240. But first, this news from NPR.
Discussing the issues and celebrating the successes of the African American community. This is Another View.
And happy Friday afternoon, everyone. I'm Barbara Ham Lee. Welcome to Another View. Still basking in the afterglow of a fabulous evening last night. I was honored by the Virginia Center for Inclusive Communities, the Tidewater chapter. They had their humanitarian awards ceremony last night and dinner, and it was just wonderful. And I am so appreciative and so honored to be included in this year's class of honorees, along with Carlos Clanton, who's the executive director of the Norfolk Education Foundation, Harold Cobb Jr., who is the rector at Grace Episcopal Church in Norfolk, Robert Nussbaum, Bob Nussbaum, a very good friend of WHRO's and a partner in Williams Mullen, and Marion Bear Tykach, president of Tykach Financial Management, also a great friend of WHRO. So just want to say thank you again to the center. Thank you to my family for coming down. Thank you to my WHRO family for being there. It was a great, great time. So we really appreciate it. So today is the fourth Friday of the month, which means it's time for Another View on Health with Dr. Keith Newby. Now, if this is your first time tuning in, Dr. Newby is a cardiologist with the Fort Norfolk Plaza Cardiology Associates, and he's also passionate about healthcare issues that particularly impact the African American community. Today, we're going to talk about Medicare and Medicaid, the impact of these programs on our community, and if the Affordable Care Act will make these federally funded insurance programs better or worse. How you doing, Keith?
I'm doing fine, and yourself?
Good, I'm doing fine. And just so the audience knows, you and I have discussed it is okay for me to call you Keith as opposed to Dr. Newby.
Yes, it is.
Okay.
It's perfectly fine. And congratulations on your award.
Thank you.
Well deserved.
Thank you. Now, when we were holding our production meeting today, I asked the group, what is the difference between Medicare and Medicaid? And everybody kind of looked and went, So let's start with that basic premise so that we can make sure our audience is tuned in. Medicare.
Okay. Medicare, as some people are already aware, is a government-sponsored insurance plan that actually fosters the needs of medical individuals or medical needs of individuals over the age of 65.
Right.
And so that is no other issues you need to be other than an American citizen and over the age of 65, and you are eligible for Medicare. And you're in the Medicare Part A and Part B, and then there's the subsequent plans. A is provides the hospital coverage. B provides the office and all the durable medical goods and equipment that you get as an outpatient. Mm-hmm. So that's a different.
And then if you want to get prescription and so forth, you do other things.
Right.
D.
Right.
Okay. And Medicaid.
Now that is again federal program for low-income citizens. So it is a certain poverty level below which you will be eligible for Medicaid. Mm-hmm. Now, there are some people who, because of disabilities, are eligible for Medicaid as a result of being disabled. Mm-hmm. As the same thing for Medicare. Now, there are some rules. I don't know all the rules that says who's able to get Medicaid from a disability. But I know that there are some patients who are maybe not necessarily fully poverty level, but they're disabled, markedly disabled.
And Medicaid is also a paid for by both the state and the feds, right?
Versus Medicare, that's all fed.
Which is completely all federal.
Right.
Okay. All right. So with the Affordable Care Act, there are some changes to Medicare. Yes, no.
Well, essentially, it's kind of it sounds like it's more of an enhancement, necessarily a replacement for it. Medicare and Medicaid are still present. It's just this is really designed. They got this middle group of people who don't have health insurance and who may be employed but can't afford it. And the Affordable Care Act was really designed to help those individuals out, because we see a lot of people. I see a lot of people in the office that just couldn't afford health insurance, and
of any kind.
Yeah, of any kind, and they need, but they aren't eligible for Medicaid because they're not poverty, but they're not eligible for Medicare because they're not over 65, and then they can't afford the some of the commercial cares because they just cost too much. So there was nothing really for those people, and they were just waffling out there in the world. So that was really what the Affordable Care Act was designed to help those individuals.
And the Affordable Care Act is going to include insurance exchanges, so hopefully that'll bring those costs down. But it also expands the number of people who will be eligible for Medicaid.
Right.
Correct?
Correct.
Okay.
Right.
So that is one of the significant ways that this change is going to happen. There are a lot of people, though, who talk about in both programs and in their current iterations that there's a lot of fraud, there's a lot of abuse, that maybe we should get rid of all of it.
Yeah. Well, I tell you, it's people get on this issue about the cost of health care, and I do agree that costs are high, but part of the problem I found with those high costs are, what you have to do to get paid in this interesting era. I mean, it takes a lot to do that, and but to get to, and I'll get to that in a minute, to answer your question about the fraud and abuse. What we're finding is it kind of is on both parts. I mean, you'll hear and read about doctors and hospitals and stuff whether overcharging, or they're like, they're actually seeing patients, but in terms of beefing up bills to try to get more money into their coffers. And you do hear about that, and I think that does happen, but I actually, to be honest with you, I see that more on the other side, the patient end. On the patient end, when they, and part of it is also accountability, and I mentioned this to you earlier. The way the system it works, there's no real system of accountability to this whole premise of insurance. I mean, everybody thinks they're quote unquote entitled. That's why it seems like they're calling it entitlement programs. I don't think that was the original design when they came up with the term, but that's what a lot of people think, that, well, I'm a citizen, I've worked. I have people that I kind of get on in the office when we start talking. They say, well, I've worked for years and I deserved to be able to get Medicaid or Medicare. I'm like, dude, you're only 35. You had worked with a couple of years of your life. I said, you're saying you deserve something. Now, that was the original plan, was designed that you would. That was like your reward for having worked all your life. And
that's why Medicare is 65 and above. Or as my mother told me this morning, when she received hers, it was actually 62. The years have gone up in terms of when you become eligible.
Yeah, and you run into these sometimes people that will they don't take care of themselves, and you try to give them tools in which to help take care of themselves, and they don't do it. And then you get into these scenarios where the costs run up because they don't do it. Like, I run into people that you put them on medications because they have high blood pressure. They come in the office, they're like 180 over 110, and you put them on blood pressure meds. And then the next time they come back, the meds are gone. What happened to the medicines I put you on? Well, I didn't want to take them anymore. I didn't think I needed them. I'm like, okay, but you just had a stroke not too long ago for a reason. That reason was because your blood pressure is high. I mean, you can't make those kind of judgment calls on your own. I mean, you can, but this is what comes out of it. But what happens is, if those people continue to have all the complications of the high blood pressure, the strokes, kidney failure, they end up on dialysis. Those are all costs, and those costs accumulate over time. And then all they do is, because people feel quote unquote entitled at times, they do whatever they want to do. They eat what they wanted to eat. They carry their life anywhere they want to. And then it happens as complications start occurring, those costs escalate. You kind of multiply that over, several million people. Those costs can be astronomical.
So you're saying that we really can control a lot of this.
I mean, we can. I mean, despite all the political rhetoric you hear and all the other things, you will find that there are people who These things can be controlled, but there has to be some functionality in which to make it controlled. As example, you have somebody say they have they're markedly overweight and they have high blood pressure and they have diabetes. Well, to me, they get on a plan. And you reward people because this is an incentive-driven society we live in. Everybody wants something out of something, and that's fine. But they give them what they want. Say, okay, you have to, in order to get this premium, at this cost, you have to meet these goals. We've done a profile on you, and this is your issue. These are your problems. Your BMI is way overweight. You need to lose
your body mass index.
Yeah, body mass index. Suppose they say, okay, you need to lose 50 pounds. Well, you get on a plan and say you'll lose 50 pounds. And as you kind of gauge that and the weight comes down and your numbers come down and you can show compliance with medications, then your insurance premium should go down. As that's your incentive to, continue, because what that's going to do is A, it's going to make you healthier. B, it's going to decrease your overall cost long term because then your relative risk of having complications down the road go down. Right now, people can do anything they want to do in Medicare and Medicaid, and there's no accountability. Right now, as an example, congestive heart failure. That's the big buzzword in the hospitals now, and it's, of course, my area of expertise. I deal with a lot of heart failure. Well, heart failure is derived from weakened heart condition and fluid overload. So if I have, say, and it's a balancing act. Look at it like if you have a sink that you kind of clog up the drain a little bit, water can still get through, but you fill up that sink right to the edge. When that sink overflows, that's like what happens in a heart failure patient when their fluid gets into the lungs, they get all short of breath and have all these major complications. If you want to keep that water level down, and that's really the key, you could tell it's a balancing act. What you take in, meaning the foods you eat, the liquids you drink. If you have a high sodium diet, then that means you're going to retain fluid, which means you're likely to overfill that sink more. If you can keep that balancing act down and your risk of heart failure goes down, then of course your cost is going to go down. Well, what's happening right now is the Medicare dings, meaning they will penalize both doctors and hospitals if, say you come in with heart failure, you get treated, and you get sent home. If you come back within 30 days, they're going to fine us because they're saying we didn't do our job well. Now, understanding how heart failure is, suppose you left and say I treated you and gave you all this literature to read through, and we went through all this stuff about sodium restriction, and then you leave inside. You know something? I'm going to go to a fast food place to eat with because I've been struggling because I wanted to have some fried chicken and some hamburgers and I didn't get a chance to do that, and I want to go do it. So you go do that. And then you say, okay, I want more. Then you steadily eating that types of food. Your sodium content is going to go up, which means you're going to go on heart failure. Now, according to the government, that's my fault.
So the doctors then get penalized under the Medicare plan now.
Right.
Because the patient doesn't behave.
Exactly. But see, they look at it as just, the person went back into heart failure too early, was saying that you didn't do your job very well. Because if you did your job well, they would be able to stay at the hospital for extended periods of time.
So that's what you mean by accountability in terms of looking at what is the total picture as opposed to how the doctor treated.
Exactly. Now, there are some people that could do a better job with how they treat people. No question. Some docs, will get them in. The buzz term is get them in, get them back out. And, there are ways we could do a better job if we're going to do it that quickly. But, see, I'm of the mindset that you get them where they need to be, you give them the education they need, then you let them go back out in the world and do the things they do. But you have to have that balance. If you got that balance, then we're looking much better long term. But if the balance is not there, then that means they're going to probably go back into heart failure. And my only thing is I say, listen, if I'm not doing my job, well, fine. I can understand that. You can, ding me, do whatever you need to do. But I can't go home with the patient. No, don't eat that. I can't go live with them. You give them what they need, but right now there's no accountability at all to the patient. None.
What other kind of ways have you seen in terms of fraud of both systems?
Well, mostly you'll see, especially with Social Security and just the disability thing themselves. You'd be surprised. I get people come to the office that stub their toe good and they say, I can't go back to work. Look at them. I'm like, what do you mean you can't go back to work? I mean, what's the problem? Or I remember a few years ago when I first came, well, I shouldn't say a few years, longer than that, but somewhere about 98, 99, I'll never forget, in the hospital, I had a patient come to ED having a heart attack. And, he's sweating, he's looking pale, his blood pressure's low. And we're wheeling him to the cath lab to kind of get his vessel open, trying to save this guy's life. And he grabbed my arm. Doc, you think I can get disability for this? I said,
wow, in the middle of having
a heart attack. I said, dude, man, listen, can we save your life first? And we talk about that later. But a lot of people have this idea of trying to beat the system. Now, I got some patients, you love them to death because, I mean, they understand what their disease process is and they want to do better. And they ask questions and you kind of get them where they need to be and they're ready to go back to work. They want to go back to work. And those people, you love them to death because they're easy to take care of. They do what they're supposed to do. It's just you get this certain subsect that will abuse the system. They're trying to find ways because they don't want to go back to work. And that's just the bottom line. They don't want to work.
440-2665 or 1-800-940-2240. We're talking about Medicare and Medicaid and its impact on the community and what we can do to try to keep our health costs down. 440-2665 or 1-800-940-2240. Now, the states have an opportunity to expand Medicaid, so that these people in the middle that you were talking about can gain health insurance, or more of them can gain health insurance. There are a lot of people who are opposed to that because, as you're saying, particularly in the state of Virginia, they're saying we're not ready yet to accept this new money from the federal government to expand Medicaid until some reforms are done.
Yeah, sometimes I just feel like it's a bunch of political rhetoric to me. I'm like, listen, if there's something, you're not going to get everything you want in all situations. So don't penalize the rest of the world because you feel like some reform needs to take place. I mean, I agree, but that's why we're in a democracy. They're going to have different views, different feelings. It may not go exactly the way you want to go, but we've become seemingly a society of leverage people, where we say, okay, I'm not going to vote on this unless you do such and such, instead of saying, okay, well, what's the right thing? What should we be doing? What should we do? And then come together and really and put across all the political things that people want this, they want this down the road, and so they and all the games that people play. Just get to this situation of what's important. What do we need to do for our community? Because that's really what it's all about.
But Keith, there are a lot of doctors who, and they are allowed to make the decision as to whether or not they're going to accept a patient who is insured through Medicare or Medicaid. And there are a lot of doctors who say, I'm not taking any more Medicare or Medicaid patients. What's the thought behind that? Because I know as you're a doctor, but you're also a business person because you run a business.
Yeah, I think what it boils down to is just a matter of what your reimbursement is to take care of those people. The one thing that people don't understand, I had a interesting conversation with a patient who told me that they felt they got mad at another doctor's office because there was some form they wanted filled out, and the doctor's office refused to do it without a fee associated. So she felt that that was wrong and it should be included. So I asked her, I said, well, why you feel that? I said, can you call your attorney and he's going to not charge you for? I mean, my attorney charges me time I pick up the phone. I'm on the phone with him like, talk quick, because so you get these scenarios where people, it's all a matter of what it costs to take care of a patient. And because again, I think I mentioned to you earlier, if I have employees I got to pay, and I have rent to pay, I have all these extra expenses, the EMR, electronic health records, that stuff costs a lot of money. People don't really understand. The government says we have to have that now.
Right.
Do you know that if you look at the average cost, you're going to pay about $100,000
to change over all of your records?
Yeah. Well, not just to change, just to even get the system. That's not even including what it costs to actually get that stuff over. And everything has a cost. So you look at, I mean, granted, I love the concept of electronic records. It's really important. It's just it does have an inherent significant cost to it. So you got employees, you have rent, you have expenses. Everything has a cost to it. So if you say like you could only see but so many people a day. So say just an example, you see 25 people a day, and your average, and the reimbursements have been going down. So what they used to pay you,
the money that you get paid for seeing those patients
steadily goes going down. So but you still have all these, and everybody wants a raise every year. So you look at what you have coming in versus what you have going out, and then if Medicare is constantly decreasing the ultimate payout.
Mm-hmm.
I mean, eventually there's got to be there's a where you're starting to lose money, and you say that people say, well, you're a rich doctor. I'm like, excuse me, I don't remember you seeing my tax return last year. How you know what I make? I mean, it's a matter of all intake and output.
Well, how do you balance the idea of, as a physician, your job is to do no harm, take care of people. And then as a business person, you have to balance the fact that you have to make the books balance at the end of the month.
That's just,
I mean, and you're not the only doctor who has to do this.
It's all planning. How you want to plan things out. Some people, you have to kind of gauge how many of these particular individuals you're going to be able to take in a day, because it has to balance out in the end, but you try your best to get more efficient. And that's my issue, is being more efficient. If I become more efficient, I can find ways to save costs in other realms. Like paper costs. People, my employees, they joke on me about that paper all the time. Don't waste that piece of paper. And I'm looking at it because if you think about how much paper we will waste in a day behind copying, printing, all this stuff, you can run into $15,000, $20,000, $30,000 a year in paper costs alone because of all the copying, all the stuff you have to do. You got an electronic system, let's start getting where we don't copy as much. We find a way to electronically create that document. We all have redundancy in our system, so we don't lose records. But I'm like, if I can find ways of cutting my costs in other realms, I want to be able to keep my employees, because I want to keep our employees. And
you want to also be able to continue to take care of as many patients as possible. 440-2665 or 1-800-940-2240. And joins us from Virginia Beach. Hi, Ann, you're on the air.
Hi. I told the fellow that answered the phone that when I'm talking back to the radio, that's what prompts me to call in. I was listening to your speaker and going, yes, thank you. Somebody's speaking out about a lot of the abuses. I happen to be married to a Spaniard, and recently his sister has had to go on disability in Spain because she has smoked all of her life, and she is now COPD. And I'm very frustrated. I did smoke when I was very young, but I quit. I had a father as a physician who smoked and died of liver metastases. So I'm so glad that your speaker is speaking to people and letting them know your own behavior is causing this expense to the system, and we're going to have to face the reality of it very soon.
What do you do, Ann, to try to encourage your own family to take care of their health, do preventative
behavior. Things? You model the behavior. You were talking about your speaker was talking about people who abuse the system, and I have 5 daughters. Out of the 5 daughters, only one has had a sense of entitlement. The rest are all hard workers. They have their own children. They model behavior by what they feed them, the meals they plan, the activities. So, it's all frame of reference. I'm not sure where that one daughter got her frame of reference, except that she's had long stays in Spain where everybody expects the government to do everything for them, and that's the only thing. She did not learn that in our family. She learned that from what she experienced in the system in Spain, and and they're paying for it now too. The Spanish government's broke.
And thank you so much for the call. I'll let Dr. Newby respond.
Well, I know where she's coming from with that. There's like It's really a slippery slope when it comes down to these issues like the smoking. The downside of those that were, say, smoked back in the 1950s and 1960s, a lot of these patients didn't know, or those individuals didn't know all the health risks associated, with tobacco use. I mean, it looked cool to smoke, a lot of people did it. And, unfortunately, so once they got addicted to cigarettes, and that is a massive addiction. I mean, I've seen people tell me, I've had patients tell me that were also, had abused crack cocaine, and they said they could give up that before they could give up cigarettes. I mean, that abuse
really?
is pretty intense. The downside is, you kind of say, okay, people get them hooked on cigarettes, and then they have to, then they pay a penalty later on because of that smoking history. And then they develop all these chronic lung conditions. I mean, it's kind of one of those things where it frustrates me because, as an example, a lot of these programs won't pay for smoking cessation classes or like the patches. They won't pay for it. But I'm like, but if we don't get these people off cigarettes, they're going to be a major cost to you down the road in other ways. They're going to develop lung problems. You're going to develop cancer. They're going to develop a peripheral vascular disease. So you see all these things, and you say, well, why don't we work to get them off this stuff now? Go ahead.
I was going to say, isn't that, though, kind of against the way the system works at this current time? It looks like maybe we're changing more towards prevention. But the system as it is right now is about illness, is it not?
Yeah, it really is. It's like, as example, like somebody that's really overweight. A lot of them won't pay for a gastric bypass procedure, some other mechanism. They won't do that. But yet, to me, I'm like, that's part of the prevention aspect, because if you get them early and you get their weight down, a lot of times all those other associated health issues go away. The blood pressure problems go away, the diabetes goes away. And it's just insane to me that I'm like, well, why am I fighting with this insurance carrier to get this procedure done for this patient who clearly needs it and would help their heart condition out and all these other things? I said, I'm going to decrease your cost long term, but yet I got to fight you to do it. So,
if you're just joining us, it's another View on Health with Dr. Keith Newby. We're talking about Medicare and Medicaid and the impact of these two insurance programs on the elderly and the poor, where our number is 440-2665 or 1-800-940-2240. Give us a call. Let us know what you are doing to, whether or not if you're actually a Medicare or Medicaid patient, and what do you think about the system? 440-2665 or 1-800-940-2240. One person wants to know when do you start applying for Medicare as you approach 65?
Well, it says you can apply for it any time, but it will go active right when
you
hit 65.
Won't go active until you turn 65.
Yeah, the day of.
And actually, do you have to apply, or does it automatically happen?
No, you have to put in. I'm not sure the actual application process, but I know there is an application process. I mean, you're eligible, and they will. If I'm not mistaken, say like you were 66 and you never applied for Medicare, and you getting stuck in the hospital for something. My remembrance says, I know with Medicaid, they will go back and say, like, because you were eligible at 65. So say you came in the hospital and you never had it, you didn't apply for it, and you did, say, okay, I'm in the hospital now, I'm stuck with all these bills, and I was eligible, you can go back and they will back pay that. Now, I know for a fact Medicaid, they will. I think Medicare as well, but I know Medicaid, they will go back.
Now, one of the benefits, though, of Medicaid is also that it covers children.
Yeah.
And so a lot of that preventive care, shots, things that they need ahead of time. But are parents taking advantage of it? That's the question.
Well, I think like anything else, health doesn't seem to at times be as much of a concern to people as you'd like it to be. I mean, my brother's a primary care doctor here in the area, and he and I were talking probably about a year ago, and I'll never forget this conversation, and it struck me as odd, but he was telling me that some of his patients, one in particular was so, African-American patient that was so glad, because I think it was he or she, I can't remember which one, but he had made it to 62, which nobody in their family had gotten to that age. So they looked at that as a major milestone to live to that age. And I'm like, that's a baby in this day and time. I mean, that's like the new 50, in the grand scheme of things, because people are living 80.
Especially as closer as I get to that age.
I thought you were only 40.
Aren't you sweet?
Well, but but those are real conversations that people have real, thought about, to say that's unusual. And that you can live to 62, and that's like, oh man, I'm so glad I'm still alive. I mean, that speaks volumes if that's what you think, because that's what your family history dictates. Not so much because of all the genetic problems, but lifestyle problems. What you're eating, smokers, people that abuse their bodies for whatever reason, and it's just, this is like the norm. This is what they're used to doing. It's a tough road, because all it's about education.
440-2665 or 1-800-940-2240. Joseph joins us from Norfolk. Hi, Joseph. You're on the air. Joseph, are you there? Hello. I guess Joseph may have left us. Oh, well, okay. We'll continue. You spend a lot of time, and I'm wondering if your colleagues feel the same way, about discussing how important it is for us as individuals to take control of our health. Because at one point in time, there was this whole thought of, the doctor as the expert. You don't question you don't ask questions, you don't question the procedure, you don't question anything because the doctor said so. And now some patients are becoming more active and active advocates for their health. But you're saying we can do a lot of things even before we get sick.
Oh, yeah. I mean, there's a lot to say about that. It's the funniest thing I always run into is I have patients that make a comment like, they come in the office with this big bag of like vitamins and all this stuff, and they put my medicine off to the side. They said this is what they're taking, and they feel like they want to go natural. That's a natural, and I started laughing to myself when they bring that in, and they start saying that, and I'm like, you realize that's a pill, right? What's natural about that pill? Somebody had to make that pill. You don't know what's in that pill, really. I say you think you know what's in that pill, but the question really becomes is that pill going to get you where you want to be? What's your data that's supporting your particular perspective? Now, I'm not a big pill pusher. Don't misunderstand. I got a lot of people that, I won't put on medicine if I don't have to. But there are some situations where there's strong data, in the literature that says this will help keep you alive. Those are the people that I will push a little bit down that road.
I have got to ask you this question. It's a little bit off topic, but with all the advertising of the various drugs and so forth, when they get to the part where they start talking about the side effects, sometimes I think to myself, there's no way with all those side effects. How do you as a doctor weigh the side effects versus the benefit of taking a particular drug?
Well, that's a very good question, because I get beat up on that on a regular basis when it comes down to trying to put people on things. And this is really what it boils down to, is risk-benefit ratio. A lot of people will hear those side effects, but again, that's potential side effects. If you look at like the PDR, which is Physician's Desk Reference, that's the books we have when we're looking at drugs, and it lists side effects. It'll give you a percentage of the likelihood of that being the case. So, if you say like a drug may have 20,000 side effects, but if you look at the percentages of it, you may see there may be 2 side effects that have like a 10% risk, and the majority of the rest of it may only be less than 1%. So you're talking about out of 100 people, you have 1 or less, or 1,000 people, you may have, say, 2 of them will have these side effects that you're listing. And I'm like, unless it's something more prevalent than that, I'm going to try to put people on it if I think there's benefit for them to have.
So that's the main thing, is whether or not it's going to benefit them.
Exactly. And again, most of those side effects, they're just saying potentials. These are the potential things that could happen.
440-2665 or 1-800-940-2240. Thomas joins us from Norfolk. Hi, Thomas.
Hey, hi. Thanks for taking my call.
Sure.
And what I want to say is that we have a misnomer here. We don't have a health care system. We have an illness care system. And if we called it that, we'd be speaking about what we really do, and that's to the point you spoke before. is we don't pay for prevention. And part of what gave me this insight was T. Reed, who I heard on NPR some years ago in his book, The Healing of America. And he points out that one of the reasons that insurance companies don't pay for preventive care in our present system is the high probability is you're going to go to another insurance company, and so that company sees it as, well, I'm not going to get the benefit of paying for preventive care. And when you have a system like Germany where even if people change companies, their level of care can't be decreased, then there would be an incentive to do preventive care and the whole preventive thing, whether it be the patch or the bypass procedure or whatever. So that's my comment.
Yeah, that's a very good comment.
Thank you, Thomas. Go ahead.
That has been noted in the past, and I think one of the things with the Affordable Care Act is they are emphasizing that prevention. But I look at it like this. I mean, and even though I know people did take that particular perspective, it didn't make much sense to me because I'm like, okay, you got people that may leave you and go to another care, but you also going to have other people leave their care and come to you. So, it really, I never understand the dynamics of why people do what they do. But one thing I've learned in this, like the insurance world, is if you really want to know why people do what they do, follow the money.
440-2665 or 1-800-940-2240. Dr. Hopkins joins us from Norfolk.
Hi, Keith. Thank you for your service to our community. You've done a great job. I have just a short comment about the efficiency within the office. I think the medical industry would want all physicians to sort of act as individuals and not collectively. And they've sold the idea that you need to have this sort of a medical computer system within each office. But I think some of you all can come together and pool your interest and have the same kind of service from your computer and pay much less if you join forces. You got this cloud computing, and that doesn't have to be in everybody's office. It's up in the cloud. So that's one thing. The other thing is that I hate to mention this. I'm not advertising for this company.
Don't name the name of the company.
Okay, but there is a company which is in our community which is advertising and for a much less money for medical servicing for medical computing. So those are my comments. And
okay, Dr. Hopkins, thank you. Yeah, right. We appreciate that. So looking for the most cost-effective ways to run the business. Yeah,
and I agree with them. I mean, that unfortunately, so trying to get people together sometimes can be a little challenging. I've tried that before. I mean, some people you can. He's absolutely right. I mean, that is how you do it, is you have to find ways of coming together to say, okay, we have this problem. How can we effectively manage this problem in a cost-effective fashion, yet at the same time achieve all the goals we want to? And there are ways of doing it, but you got to get everybody on board, and that's the challenge.
That's the challenge. Mark joins us from Norfolk. Hi, Mark. You're on the air.
Yeah, good afternoon. Dr. Newby, kind of to piggyback the last couple of callers, I was just, wondering is that, well, first of all, healthcare is just, absolutely through the roof. For self-employed individuals, it's the size of a mortgage or stronger if you've got a family of 4 or 5. It's just to the point where it's not even affordable anymore. And what I just wanted to know, I know you mentioned you've done a couple different partnerships, but what I was wondering is that I don't have a lot of faith in the current system that it's going to correct itself anytime soon. At the same time, I think that the people who are uninsured, that pool is just increasing by the numbers exponentially. So what I wanted to ask you, would it be possible within maybe your own network or you individually to where you could actually establish your own plan within the office to the point where if I wanted to be your patient, you could say, hey, look, it's going to cost you and your family X amount of dollars, X amount of thousands of dollars per year for me to be your primary. And then maybe have just a network with a couple specialists to where, within your network, you could refer out to a specialist could refer to you, to where those costs could kind of be kept out, to where you could actually almost establish
kind of a private insurance plan per office. I get you, Mark, and I want to give Dr. Newby time to respond. Go ahead.
Yeah, actually, that's some people do that now. They call it more like concierge kind of practices. I mean, I've looked at that. I've never had any issue with anything that works in the end, because I understand what his perspective is. I mean, this stuff is insane, the cost that you have to do. And then you say, well, shucks, why give it to insurance carrier for him to tell me I can't get this procedure done anyway if I'm investing all this money, and I might as well just give it direct to the source.
So if you did a concierge service, you would service whatever needed to happen, as opposed to having a laundry list of things that could not be covered.
Yeah, the downside though is just the say if something happens, you have to go in the hospital, and you don't have health insurance, then you're kind of stuck. That's the only, or you have some massive catastrophe happen. Mm-hmm. Now, granted, most young people, I don't know how old. I think it was Mark. He sounds young on the phone. I would think probably mid-30s. That's or maybe low 40s. I mean, the likelihood of him having some massive clinical problem is going to be pretty small. It's just unfortunate in this world. You never know.
That's very true. Candy joins us from Newport News. Hi, Candy. You're on the air.
Hi. I am just really frustrated about all these people that are bashing disability and things like that. I'm on disability. I'm 54 years old. I got it through my work. I have Bichette. It's not anything I did to myself. And they are requiring me to use Social Security. I have to go through Social Security so the insurance company doesn't have to pay for my disability, basically. I'm on food stamps. I am barely surviving because I'm separated from my husband. Fortunately, I have insurance because I'm not divorced yet. But when that happens, I'll be one more person in the system. I don't understand why people don't have a little more compassion for people that are actually sick and actually have issues going on.
Instead of abusing the system. That's a good point. Go ahead, Dr. Newby.
Well, I think, you misinterpret what
Thank you, Candy, for the call.
What the point of it was is just those people. There are people in the system, and I made a point earlier that do need it. And those people that do need it, there's never an issue or concern. I think, at least not in my mind. I can't speak for other people, but in my mind, I've always said those. I'm a moderate. I consider myself to be a moderate. I think there are a lot of people who do unfortunately have conditions that have come about that they have to have help, and I think that's our job as people, Christians, whatever you may be. Mm-hmm. To assist other people, and that's never the issue. It's the other. It's the little subsect of people that sometimes that you get a little frustrated with because, again, if I have somebody come to my office who really, and I've had people that can walk in the office. I mean, and when I say walk, I mean walk well. Mm-hmm. And yet they're on disability, and then I'm like, why are you disabled? They say, because of my heart. I'm like, well, your heart's not that bad. Why are you disabled? And they really can't answer it, but they kind of got themselves situated where they were able to get disability for that or some injury. I had one guy that had a broken ankle, and he's been on disability for 20 years. And I'm like,
how does that happen?
I don't know. I mean, that was my point exactly. I said, how did you get that? Like that, or but they found ways of,
But that makes the cost go up again, and it causes problems for everyone.
It's almost like what I've had patients that would do. They'll beat you up so bad, calling your office and fussing because you're not giving this form up, that form up, and they've actually kind of pushed doctors into say, okay, just to get them to leave me alone, I'm signing on this form. But that doesn't make it any better because, and again, it's only a small subset of people that you run to that problem with. The majority of people, that are on that, I think legitimately probably need it. It's just it's just how you gauge those ones that don't, and that's where you run to the problem.
We got a little less than 2 minutes left. Overall, what would you tell everyone, all of us, including doctors, everybody, what we can start doing right now to start lowering some of these costs?
I think if the government could ever get things straight, with each other and say, okay, we have this problem. How do we really lower these costs? a lot of what they are doing, what they're saying is legitimate in that if you prevent the illness, then that will ultimately reduce the cost. But this is an incentive-driven society. You got to give people a reason why they're going to do that just for their health. They say, I don't worry about my health. Some of them really feel that way. You have to, if you can incentivize people to say, okay, if you do this, if you meet this criteria, then this will happen. And then you can show some cost savings, some other things. I think you will get more traction with that, than you can with anything else we're doing currently. So if they can get that part out, I'm telling you, I have no doubts in my mind because I've seen it real time when you see illnesses get better, with certain treatments. And then the reduction of the complications goes way down. So if you can do that, then you talk about a massive decrease in cost just on that alone.
Okay. You'll be back next month. And we also want to encourage the audience to send us a note on anotherviewradio.org. Let us know about a topic you'd like Dr. Newby to discuss, and we can do that.
I'd love to.
And we'll be right back.
Thank you.
Hi, I'm LaShawn Merritt, and if you want to discuss the issues and celebrate the successes of the African American community, listen to Another View on 89.5.
And welcome back. Thank you, LaShawn. We appreciate the promo. We've all heard stories about what goes on inside our high schools, the good, the bad, and even the unimaginable. Well, a new PBS documentary allows us to be flies on the wall of one D.C. high school, taking us inside the building for an entire year. It's called 180 Days, A Year Inside an American High School, and gives us an up-close look at the struggles students and educators face on the road to academic success. Our Lisa Godley recently spoke with the coordinating producer of the documentary and the principal featured in the film, who were happy to share a little of what you'll see.
As the first principal of a new high school, Tanisha Williams Minor really had her work cut out for her. The building was a former elementary school that had to be transformed, and that was just the tip of the iceberg. Test scores were low, and resources were limited.
So our assistant principal was actually also the internship coordinator. He had to ensure that the kids went to their internships and kind of delegate, figure out how often they were going, if it was productive, if we needed to make changes. So a lot of the obstacles were any typical obstacles of opening a building and instituting a new program and then having a completely new principal with new staff members.
There were also the challenges her students faced outside of school that made the road to graduation even rougher.
Every issue that a typical teenager goes through, compounded with some things that adults go through as they are struggling. Just having to work, having to figure out where the meal is going to come from, having to figure out how you're going to visit someone in a hospital and be a support system to someone who is ill, having to figure out how you're going to be a support to your friend who's mother or best friend just got killed. So there were all of these life issues that plagued our kids, compounded with them not doing so well in school. It's as if they were a block and all these issues were just chipping away. It was kind of one thing after another.
As they began taping the documentary, 180 Days, A Year Inside an American High School, Minor, a graduate of Norfolk's Maury High School, was a little apprehensive, but she soon got used to having cameras everywhere.
All of that for all of you. I want you guys to walk across the stage just like I want you to go to class every day. I cannot express to you the feeling that you will have at the end of graduation. You just have to experience it.
Alex Agri, an NSU graduate, was the coordinating producer of the documentary. She says they studied a lot of documentaries covering the dropout crisis before deciding which approach they'd take.
A lot of what we noticed was that there was a voice missing, and that was the voice of the teachers that were being riffed by and large in DC public schools, and all of this media surrounding it, but no real stories of the teachers and none of their perspective of what was going on in the classroom.
Agri says of all the teachers and students profiled in the documentary, the story that impacted her profoundly was a young man named Rufus.
He comes into the school a very challenged student. He's a truant. He's been kicked out of several schools. He's adjudicated, has a criminal record, and came from a two-parent home. His mother was diagnosed with stage 4 cancer and was in hospice when he came to DC Med. I'm grown, and I can't imagine the loss of a mother and then having to continue.
Come on. Had a wake-up call, kind of just a self-check, just sitting around, wow, where will I be in about 20 years? I just don't want to grow up and just be that guy who's always saying, what if?
180 Days shows what can be accomplished when dedicated educators refuse to give up on their students.
I am not displeased with the way that I ran the ship, and I believe that it was always about the kids.
And then we were able to graduate kids who were all accepted into college, kids who never thought that college was an option for them. We were able to say, hey, every single one of you guys has gotten into college, and that's amazing. Now we're gonna go and we're gonna make sure that your life is changed for the better forever.
For Another View, I'm Lisa Godley.
And 180 Days, A Year Inside an American High School, airs Monday and Tuesday, March 25th and 26th at 9 p.m. on WHRV-TV 15. Time now for things to view and do in Hampton Roads.
You will be my Saturday love.
Newport News Councilwoman Tina Vick will host a community discussion on violence tomorrow, Saturday, March 23rd, from 3 until 5 at the Denby Community Center, Warwick Boulevard in Newport News. Come join the discussion on how to reduce violent crime in that city and in Hampton Roads. For information, call 926-8634. The Norfolk FBI is holding a free seminar on parental awareness Tuesday, March 26th from 6 until 8:30 at ODU's Engineering and Computational Science Building, Alcorn Avenue in Norfolk. Come find out how to protect your children from online predators and gangs. For details, call 455-3161. Also on March 26th, Hampton University and the Commonwealth of Virginia host a one-day event to create access to opportunity for small, women, and minority-owned businesses in Virginia. It's from 8 until 3 at Hampton University's Student Center. Come learn how to bid effectively for government contracts and apply for private sector opportunities. To participate, visit dmbe.virginia.gov. And come laugh the night away at the Downing Gross Cultural Arts Center Pearl Bailey Comedy Showcase featuring Newport News native Coco Brown. It's Friday, March 29th at 8. Information is available at 247-8950. And finally, the Hampton Citizens Unity Commission is seeking applications for its 2013 Unity Awards. The award recognizes individuals, initiatives, organizations, and businesses that have had a positive impact on racial and cultural diversity in Hampton. To nominate, visit hampton.gov/unity. Applications must be submitted by Friday, April the 12th. Another View proudly received the Hampton Citizens Unity Award in 2010. These and other events are on our website, anotherviewradio.org. On the site, you can download the podcast of today's or any other Another View program, sign up for our eView newsletter, a once-a-week reminder of upcoming shows, or drop us a note about the show. Next week, how 2 Hampton Roads cities took specific action to make sure women and minority-owned businesses get a piece of the procurement pie. If you own a business, you won't want to miss this show. For producer Lisa Godley, audio engineer Perry Smith, Kendall Harrison, who answered our phones, I'm Barbara Ham Lee. Have a fantastic weekend, and let's get together again next Friday at noon for Another View.